Welcome to session 1 on learning domains and principles of assessment. Objectives of today's session: to explain all the three learning domains and the key principles of assessment in medical education, apply appropriate teaching and assessment methods for each learning domain, to analyze the strengths and limitations of objective versus subjective assessment methods, and finally to reflect on your own assessment practices in your routine daily practice and identify areas for improvement in your teaching. Now, why learning domains are important in medical education? As we graduate throughout our MBBS, we develop comprehensive knowledge in various subjects, and this knowledge we should be able to demonstrate in clinical scenario. So we should be able to perform various clinical and procedural skills. Also, we should be able to demonstrate or exhibit empathy, ethics, and professionalism. Integration of all the above will ensure competent and compassionate physicians. These are the basic three domains of learning: the knowledge, skill, attitude, and communication. Cognitive domain is basically the development of knowledge base. For example, develop the knowledge to understand and comprehend the pathophysiology of atherosclerosis and myocardial infarction. So we are developing knowledge by studying various subjects across maybe MBBS phase 1, phase 2 or phase 3. Similarly, the psychomotor skills have to be developed, for example, in this case to develop the ability to measure blood pressure using standard protocols. Attitude and communication is equally important. We should be able to develop the ability to gather the information about all the cardiovascular risk factors in an obese individual and be able to give him the dietary advice to prevent myocardial infarction. So if the student is able to do that, then all the three domains, the learning is occurring comprehensively. It should not be only limited to the cognitive domain. At the same time, they have to develop psychomotor and affective skills also. There will be various teaching methods which may be adopted based on these three learning domains. For cognitive knowledge domain, we can have didactic lectures, case-based learning sessions, problem-solving sessions. For psychomotor domain, we have practical sessions, we have dope sessions, skill lab, simulation lab, bedside teaching. For affective, that is for attitude and communication skills, it's difficult. We can use role plays, reflective writing and patient narratives. We can adopt different assessment methods based on different learning domains. For example, cognitive domain, we may go with the written test, may be in the form of either MCQs or essay questions, or even Viva voce may be conducted to assess the knowledge. For psychomotor domain, we may use OSPI or OSCE stations using skill checklists, or we may also go with direct observations. For affective domain, it's slightly complicated. We can use reflective writing or peer assessment or using some of the rating scales and rubrics. What are the different types and purpose of assessment? We have something called as formative assessment and summative assessment, what commonly we use in the present day assessment. Formative assessment is nothing but assessment for learning. Here, how can we use the assessment to help the students learn more? Here, there is monitoring of progress of the learning. Feedback is given for the students after each assessment. This is going to aid learning and improvement in the learning. So this is a low stake examination where the students have the opportunity to improve in the future assessments. The summative assessment, at the same time, here it is assessment of learning, means we are assessing how much students have learned at a particular point of time. So this is mainly to assign grades, making decisions like pass or fail. So it is a high stake examination. There is something called as assessment as learning, which is at the higher level actually, where the students are able to learn about themselves as learners and become aware of how they learn at the metacognitive level. Means here the students are developing themselves as an independent learner. The self-directed learning ability is getting inculcated among the students. Now they are reflecting on their learning process. They are taking the responsibility of their learning process. So this is assessment as learning. Assessment should cover the whole range of competencies at different levels of clinical competence as shown by Miller's pyramid of competence. So if you see in this Miller's pyramid of competence, at the base level we have knows and knows how. These are the two levels which can assess the cognition, that is the knowledge base. Either it may be at a very basic level wherein it can be a recall type like just the MCQ kind of a question, or it can be an interpretation or an application based question where we have some scenario based essay questions or even the case presentations can be included at this knows how level. Higher the competence we have shows, means the individual who has developed the knowledge will be demonstrating the skills which he has developed. So here we can use standardized patients, simulations, OSCE stations, or even the skill lab based assessments. The final and the topmost where the individual becomes an expert is does, means what he is doing at the workplace, that is a real life situation. So this can be assessed by direct observation. So we have to include different types of assessments and also at different levels. We should be able to assess all the levels, knows how, shows and does. Does is mainly when the student graduates during the internship or during the post-graduation period, but at least still shows, knows how and knows can be assessed during undergraduation. Now we'll try to understand the key principles and attributes of assessment. We have to understand this because whenever we are choosing a particular assessment tool, we should know whether whatever tool we are using will be assessing whatever we are expecting to assess. The first one in this is validity. Here the test tool measures what it is intended to measure, that is on the bullseye. So I want to see the clinical skill among student, I will be using OSCE. So this perfectly fits to assess the clinical skills. I cannot ask a long essay question to assess the clinical skills. So here OSCE is a valid tool to assess the clinical skills. Reliability means consistent and reproducible results. If I am using a particular type of an assessment tool, among all the students, it should reflect the similar results and it should not affect the results in a subjective way. Secondly, if I am using it across different time period also, it should give reproducible result. So here by structuring the questions, the reliability improves. Feasibility and cost effectiveness. Test tool should be practical in terms of time and resources available. Educational impact, it should drive the learning in desired direction. The assessment tool, whatever we use, should be towards the learning goal, the outcome. Acceptability, it should be acceptable by students and faculty. We have something called as utility index, which is a product of all the above key principles. So if anything is zero, the utility will be zero. So we should ensure a balance between all the attributes of assessment. How can we improve validity? Align the assessment tool with learning objectives. If I am using an OSCE or a mini CEX for clinical examination and history taking, then the validity is good because that particular examination system, the assessment with the structured checklist is going to be suitable for assessing clinical examination. Match with the course content, means whatever questions I am asking should cover the whole content across the subject. For example, blueprinting, like weightage allocation for different chapters in a particular or different competencies, if I can take as an example, weightage can be given to all the competencies and blueprinting can be developed. So the sampling of all the content will be good, which improves the validity. Use of multiple assessment tools at all levels of clinical competence will improve validity. For example, in cognitive, if I am having a written test examination, a mixture of MCQ, long essay, short answer question is always going to be useful, which can improve validity instead of using only long essay questions or only MCQs. Or we can combine cognitive with psychomotor with affective domain assessments. Like if I am using a cognitive long essay question to describe the pathophysiology of hypertension, psychomotor I may ask the student to measure the blood pressure. In the affective domain, I can ask the students to give a dietary advice to the hypertensive patient. So this is a comprehensive evaluation of a particular competency. Piloting and reviewing the assessment tools is going to be very useful. If it is not found appropriate, we have to revise it. Authenticity is again going to improve validity. The case scenarios, the real life scenarios, whatever we use should simulate the real practice. So we can use scenario based applied questions, case discussion, ward rounds to improve the authenticity and hence to improve validity of the assessment. And how to improve reliability. So here structuring of questions. If there is a long essay question, I can structure it so that the marking becomes uniform. Using of OSPI and OSCE stations instead of a long case discussion. Yes, this can improve reliability because the varied checklists are going to be used for this. Increasing the number of items or stations. For example, if I am taking an MCQ, okay, so 2 MCQ on CPR is less reliable than 20 MCQs. If I am taking OSCE, 12 to 15 stations would be more reliable than creating just 3 or 4 stations. So that is increase the number of questions, but it should be in a feasible way. The number of questions should be ideally more to cover the content and it will become more reliable. Multiple assessors and training the assessors. This will reduce inter-rater variability and averaging of the scores from all the assessors will increase the consistency. Use a standardized scoring systems. The checklist whatever we are going to use to certify the students should be standardized amongst various experts. Use those checklists, rating scales and rubrics so that the subjective variability is removed. Here are some of the examples for validity and reliability. The first one is reliable but not valid. To give an example, MCQs without proper blueprinting of the content. MCQs are no doubt reliable because every time any student answers, they are going to score the same. But they are not valid here in this case because there is no blueprinting of the content. If proper blueprinting is done, then it becomes valid also. Viva OC is low on validity and reliability because of its subjective component. Unstructured short essay question to demonstrate measurement of BP. So here the student has to demonstrate the measurement of blood pressure, but we are asking a written test question to write about the measurement of blood pressure. So it is not reliable and not valid. OSCE mini CX using rating scales is both reliable and valid because they are structured checklists and also the clinical examination is best assessed with these two tools of OSCE and mini CX. Finally, a word on objectivity versus subjectivity in medical assessments. Here the objective assessment means the score is independent of examiner's personal judgment. So here you have the same answer, you will get the same score. But in subjective, it is influenced by the examiner's interpretation and opinion. Like MCQs, OSCE using structured checklist will be more objective, whereas long essay questions, while long case presentations will be subjective assessments. Here scoring in objective is fixed using a checklist, there it is varied. Reliability is more with objective assessment and at the same time, validity is very high with the subjective assessment. Bias is very low with objective and it is high with subjective assessment. Results may, however, be disappointing with more objective assessments in clinical scenarios. So, do not use highly reliable tools at the cost of validity. Objectivity will definitely ensure fairness and reliability, but subjectivity is always essential to evaluate reasoning skills, your professionalism, empathy, which you can't assess objectively. So, subjectivity cannot be avoided, but it can be well embraced. A meaningful compromise can be made while selecting assessment tools. Together, they ensure competent and compassionate doctors. To summarize, assessments should be aimed towards program goals and learning objectives. Assessment should be planned in all learning domains and cover a whole range of clinical competence. Any single assessment method can never be perfect on all the attributes. So, use multiple assessment methods and multiple assessors to ensure right assessment at the right time for right purpose. Competency-based assessment should be more formative. Use structured checklists. Workplace-based assessments give value for qualitative judgments and feedbacks from experts. Good assessment involves a mindful choice about where and how to compromise. Thank you.